Good morning, friends. So at the outset, I wish to thank CRITIC team in having me for this meeting. So my sincere apologies, I couldn't be present in person because of an health emergency. So I'm sending this as a recorded version. So the talk I was given was on lung and diaphragm protective ventilation. So very interesting topic. In fact, I need to thank Deepak who assigned me this topic because it was quite a challenging topic for us to deliberate upon. So we'll just take you through the overview as to what do we understand by this new concept called diaphragm protective ventilation. So I think first thing is for us to understand what do we know so far about the diaphragm and its role in critical care. So this is just a representation as to how diaphragm looks. So the whole problem in a ventilated patient is diaphragm undergoes atrophy in mechanical ventilated patients, and this atrophy is directly proportional to the duration the patient is on mechanical ventilator. And when diaphragm undergoes atrophy, it does has a bearing on increasing the ICU length of stay. And obviously, when someone is staying in ICU for longer time, the complication rate also increases. So this is the fallout of diaphragm that undergoes atrophy in patients who are mechanically ventilated. Longer they're ventilated, the greater is the atrophy. On the same note, as intensivists, we understand because of our over resuscitation, positive fluid status, positive fluid balance status. So there's a lot of edema that can happen in the diaphragm, and the opposite also can happen where diaphragm thickness also can increase. And this thickness also would increase the concomitant risk, especially in mechanically ventilated patients where there's a lot of edema that can happen in the diaphragm. So on one end, you can have atrophy because of disuse. On the other end, you could have swelling or the edema that also leads to dysfunction of diaphragm and leads to complications. So this is well established fact. And it is shown that in someone who is on a long-term ventilation, the thickness of the diaphragm reduces to 6 to 7.5% of the diaphragm reduces in thickness per day. And this percentage is lesser in children, which means as we age, the atrophy or the thickness reduction is much more pronounced in elderly patients. So the way we can assess diaphragm is ultrasound is the best tool at this point of time. We'll talk about other ventilatory strategies and this just understand what we know so far. So diaphragm excursion and then peak inspiratory amplitude and diaphragmatic thickness and thickness fraction of diaphragm. So these are some of the modalities. There's a separate video you can watch as to the modalities, how we can assess diaphragm. So now coming to the topic, protective lung ventilation is a well-established fact. So we understand that low tidal volume, maintaining plateau pressure less than 28. So all these are well established. But protective ventilation to safeguard the integrity of diaphragm is not well established. So there's no established approach. And it is shown in someone who is mechanically ventilated even for 24 hours, who is on a controlled mechanical ventilation. 64% of the patients do demonstrate that there is a diaphragmatic weakness that would have set in already. And it is shown that 80% of the weaning difficulties that any patient in ICU would have is significantly due to the diaphragmatic weakness or dysfunction that would have set in. So all the weaning, 80% of the patients where you have weaning difficulty, diaphragmatic dysfunction is one of the common factors. So that is something we need to understand as the backdrop. So another thing for us to understand is when someone is on a control. So if you see my narrative, the whole emphasis is controlled mechanical ventilation, which is considered as a very sanctified version, is being challenged now when you have to look at optimizing your diaphragmatic function, because that's what is being shown. So in controlled mechanical ventilation, we understand there is atrophy that sets in, which we call it as ventilatory induced diaphragmatic dysfunction. And we have clearly understood even 24 hours of mechanical ventilation leads to this diaphragmatic dysfunction. And the reasons for this, there is pathological reasons or pathogenetic reasons for this. Prolonged mechanical ventilation is shown to cause mitochondrial dysfunction, leads to reactive oxygen species activation, leads to proteolysis. Basically, there is a melting away of the muscle fibers. This is very clearly shown. And it is also shown in certain studies where the diaphragmatic atrophy or dysfunction has a direct correlation to the survival, as you see in these graphs. Where there is no diaphragmatic dysfunction, survival rates are much higher. But where diaphragmatic dysfunction sets in significantly, there is a progressive decline in the survival. And this has been shown in small experimental studies, which has come from France and US. So now going to what are the strategies that we should adopt to protect the diaphragm. So what we have understood is when lung has a pathology or there is a pathognomonic problem in the lung, so the whole ventilation is taken up by baby lung. And we understand this very well in ARDS, that the baby lung concept where we need to protect this lung. And this baby lung is subjected to a lot of stress and strain. So pictorially, if you have to see, if you have a patient with ARDS, so the type of alveoli that are present is very heterogeneous. There are some alveoli which are derecruited with exudate edema. There are some alveoli which are collapsed, and there are some alveoli which are over-distended. All this do put enormous stress and strain on the baby lung. And another thing that we have recognized is there is significant ventilatory dysynchrony that happens with the patient. And that also puts a lot of duress on the baby lung. And what we have increasingly recognized is providing extra sort of a support from the ventilator, which is not needed for the patient. So excessive ventilation, what we say, excessive ventilatory support, not commensurating to the patient's need, also puts stress and strain on the lung. And over sedating or giving more analgesia, more so using more neuromuscular blockers, also is shown to produce stress and strain on the baby lung. So the whole gospel of my talk in this slide would be over ventilation or under ventilation, both have a duress on the baby lung, or they put more strain on the lung. And this leads to disuse atrophy, and that has shown to cause diaphragmatic dysfunction. So you are providing additional mechanical ventilatory support, not commensurating to the patient's demands, or which is overwhelmingly more than what patients demand. It can lead to lazy diaphragm and diaphragmatic dysfunction. And this strain on this baby lung, due to all these reasons, would lead to ventilator-induced lung injury, which is compounded by the inflammatory process that is happening within the lung and into the systemically the inflammatory process that may be present. So now we have spoken about over ventilating, and it is also shown that under ventilation. So if the ventilation you are providing is suboptimal to the patient's need, that also produces stress and strain on the baby lung, or you are not keeping the patient optimally sedated. So too much is bad, little also is bad. That's what this slide is telling. So more sedation, more analgesia, more neuromuscular blocker is bad. That also produces stress. Or under ventilation, under sedation, or under analgesia, that also produces stress and strain on the baby lung. And this leads to a concept called self-induced lung injury or self-inflicted lung injury, PCL. And this was well recognized during COVID in tachypneic patients. I'm sure most of the listeners would understand. So this is a pictorial representation how overdoing with ventilation can provide duress on the lung and on the diaphragm, or underventilating or underdoing things also produces stress and duress on the lung. And another important aspect in this picture is the PEEP aspect also. And we have clearly understood the less of PEEP also is harmful, or excessive PEEP also is harmful. And this has shown to have deleterious effect even on the diaphragm. Less is harmful to diaphragm, more is harmful to diaphragm. So now coming to understanding what are the mechanisms of injury for the diaphragm. So as I said, over assistance is not good, under assistance is not good. What happens is during expiratory phase, the diaphragm tends to contract. And this contraction compounded or coupled with dysynchrony leads to something called eccentric myotrauma, which leads to diaphragmatic dysfunction. If you provide high PEEP, the PEEP more than what is needed for the patient, that leads to shortening of the fibers in the diaphragm, that leads to dropout of the myofibrils within the diaphragm, and that is called expiratory myotrauma. So this myotrauma is used interchangeably, distinctly for the diaphragm. And now we have understood the type of injuries to diaphragm that can happen with under ventilation, over PEEP or under PEEP. Now the big question remains, practically, how do we monitor for the diaphragmatic dysfunction? What are the monitoring strategies? For this, I will be going a little more physiological. It may look overwhelming, so you can listen to this video again. So the variables that mediate injury to cause more lung stress, or there is, so I'm sure most of the listeners know transpulmonary pressure as an indicator of the lung injury that may set in, because the transpulmonary pressure is what we take as a surrogate of your driving pressure. right? I think we understand that very clearly. We understand that the plateau pressure, we equate it to transpulmonary pressure and say this has a bearing on the driving pressure. So here we are trying to split that. So the lung stress that is caused, we are splitting this transpulmonary pressure into two aspects. One is dynamic transpulmonary driving pressure. As we say, initially we understood the concept of only the plateau pressure. Then we understood the concept of driving pressure, which is plateau pressure minus P. So is the case in transpulmonary pressure. Now we are splitting the transpulmonary pressure into dynamic transpulmonary driving pressure and peak transpulmonary pressure. And the variables that mediate injury can also be due to the respiratory effort or the respiratory muscle function. And this is equated to airway driving pressure, which we simply called as P flat minus P. But now it is recognized this airway driving pressure is influenced by transpulmonary driving pressure along with the chest wall driving pressure, because this chest wall driving pressure is something that we don't factor in as one of the reasons which can increase your transpulmonary driving pressure and the concomitant lung injury, which means chest wall also has a bearing on causing increase in the transpulmonary driving pressure. So changes in the chest wall can lead to increase in the changes in the transpulmonary driving pressure, can increase the lung stress. So this is what we understand. Then there's something called global respiratory muscle effort, which is a esophageal pressure time product. Will not dwell into this. Then there are direct ways of measuring diaphragmatic function by electrical impedance. We put electrical activity of diaphragm. Basically, you put a probe on the diaphragm, measure its electrical activity, and the normal is put as 4 and 29 microvolts. That is something you can remember. Obviously, this is something which is unavailable, and maybe in future it may get available. So how do we do it on the bedside now in our ICU? So there is some component which is very easily available in the newer ventilators, which I will show you. So there is something called a airway opening pressure. So this I'll just explain. So AWOP, I will show in the next video how I did it in my ventilator. So this is the deflection in the pressure when there is an inspiratory effort against an occluded airway for 0.1 second. So listen to this carefully. The deflection of pressure that happens when there is an inspiratory effort. That's why I'm showing a waveform where there is an inspiratory effort against an occluded airway for 0.1 second, which will tell you the respiratory drive, whether it is low or whether it is high. So again, listen to this. So the deflection in the pressure because of the inspiratory effort against an occluded airway, which is called AW. The reason I'm repeating this 3 times is this is something you can do on a bedside in your newer ventilators. I will show you in the next video. So this has to be between 1 to 4. If it is less than 1, then you know respiratory drive is less. If it is more than 4, you know respiratory drive is high, both of which can cause stress on the lung, baby lung. So you have to keep it between 1 to 4, which you can do it in the ventilators. Then there's another concept called the deflection in the pressure because of the inspiratory effort against the airway occlusion for the whole of the respiratory cycle, which is called delta P arc. And this is seem to correlate very well with the dynamic transpulmonary driving pressure. This is not available in the ventilators I have in my ICU, but AWOP 0.1 second is available in the ventilator, which I'll show you. And there is another concept of end inspiratory occlusion, which will again determine the excess respiratory effort and the dynamic lung stress. And this also we did not have, but end inspiratory occlusion, what we do will give you a driving pressure. But here we are talking about your respiratory drive. For that, you need to do at the beginning of the inspiration, where you look at the inspiratory effort and change in the pressure against the occlusion of the airway occlusion. So I'll show you. So this is the video I have done in my ICU. And as you see, AWOP 0.1 second, airway opening pressure 0.1 second should be 1 to 4. And this is the ventilator. I'll just show you a video recording how we do it. So as you see, go to lung mechanics. And then once you put the lung mechanics, there is a 0.1. We press that. And you see that red button. So it's put a pause for 0.1 second and you get a 1. So which means the respiratory drive for this mechanical ventilator patient was reasonable. It was not under or it was not over, but little on the lower side. Then you have to obviously optimize your trigger and try to increase the respiratory drive. So this is how it looks. So I'll just take a snapshot. If you couldn't identify, you go to the lung mechanics. There is something called P0.1, which means you are looking at deflection in the pressure because of the inspiratory effort against an occluded airway for 0.1 second. As soon as we press this, you get one sound which denotes there is a valve that is closed for 0.1 second, and then it will give you a reading there. Because here you see reading is 0, which means respiratory drive is weak, which is producing stress on the lung. So this you can do. This is our GE ventilator where this is available. I don't know about other ventilators. So please go back and look into these lung mechanics, and you may have this. Okay, now very quickly we'll look into tabular format. What are because the topic is protective ventilation for the lung and diaphragm. So we'll go tabular format. So for tidal volume, you know the parameter. The whole reason of optimizing tidal volume is to prevent ventilatory induced lung injury. For that, we all very well understand the tidal volume that we need to maintain is a lower tidal volume. It is 4 to 6 or 8 per body weight. And the second way that we optimize protection of lung and the diaphragm is to prevent asynchrony. So the key thing is to look at your flow time or flow volume loops and try to maintain synchrony. There is a detailed video on how to identify synchronies and how to manage that. Please go and watch. So maintaining synchrony is the way to prevent the stress on the lung. And then this is the deflection in the pressure due to inspiratory effort against an occluded airway for the whole cycle. And this we did not have in our ventilator. Some other ventilators may have. For the whole cycle occlusion you do, and then look at the change in the pressure, and the dynamic pressure change that is acceptable is 8 to 20 centimeter. So for all the trainees, remember most of these pressures. So when we look at the plateau pressure, we say 30, driving pressure, we say 15. So all this, what I'm talking, the transpulmonary driving pressure or your driving pressure, or you are looking at the esophageal dynamic pressure, all this comes between around 5 to 20. So that is the easiest number to remember. So your pressures have to be in this range. And dynamic transpulmonary driving pressure, as I said, it is 15 to 20. So all these numbers come between 15 to 20. So it's easy for you because you know driving pressure has to be less than 15. Most other pressures, you call it transpulmonary driving pressure, or you call it esophageal pressure, or you call it transpulmonary pressure. All this, it is in a very simplified format for all the trainees. It should be around 15. So if you remember the number 15 to 20, it should be around that range. And dynamic transpulmonary driving pressure also should be less than 15 to 20. And there is something called transdiaphragmatic pressure that we measure by direct probes put on the diaphragm. Even that, your change in the transdiaphragmatic pressure also should be around 15 centimeter water. All these pressures, which is around 15 to 20 and less than 15, indicates that the stress on the diaphragm on the lung is acceptable. Anything more is bad, anything less also is bad. So that is the take-home message for you. And this is the various waveforms. So here you see the flow time, and here you see the plateau pressure that is being measured. This is the esophageal pressure, and this is the transpulmonary pressure waveforms. So this can be shown in the exam. So just pay attention to all these graphs. So very quickly, so what is the other practical way of assessing diaphragmatic function? There is a separate video on how to ultrasonologically assess. So this is the easiest way for us to assess the diaphragmatic function, and the one that is shown to be more representative of diaphragmatic dysfunction is the diaphragmatic thickness and thickness fraction of diaphragm. So here you have to look at the costophrenic angle. There is a video you can see. I'll just briefly cover. So you have to look at the costophrenic angle, and here there is a costophrenic angle is where there is approximation of all the structures: parietal peritoneum, from lung, pleural space, and parietal peritoneum. So we have to put the curvilinear probe at the anterior axillary line. So you get a picture like this, where this is the pleural layer, diaphragmatic layer, and peritoneal layer. So the diaphragmatic you do with the 6 to 13 hertz ultrasound, and diaphragmatic thickness has to be captured on the M mode in the end inspiratory and end expiratory. And then you have to do diaphragmatic thickness diameter, which is diaphragmatic thickness during inspiration minus diaphragmatic thickness during expiration. This is the diaphragmatic thickness difference in inspiration and expiration. And then you have to look at thickness fraction diameter, which is calculated by diaphragmatic thickness difference divided by diaphragmatic thickness during expiration into 100. It's very easy. You can please look into that video of diaphragmatic assessment, and the thickness fraction diameter less than 20% will clearly indicate there is a dysfunction that is set in. So this is how you do the assessment. So that is in brief about how sonologically also you can estimate your diaphragmatic dysfunction. So what are the targets? Now we have spoken about physiology, we have spoken about pathognomonic aspects of diaphragmatic dysfunction. We looked into the physics as to what happens with various pressures. So what should be our targets for diaphragmatic protection? So our products is your inspiratory effort should not be too much or it should not be too less. It should be modest inspiratory effort. PEEP has to be optimal. It should not be too much and too less. Sedation should be moderate. It should not be too deeply sedated or less sedated. And too much carbon dioxide is bad. So if too much carbon dioxide is there and you're not able to control, you have to look at ways to remove carbon dioxide. And neuromuscular blockers should be partial and try to avoid using as much as possible and resolve asynchrony. Now we have artificial intelligence which is coming in, which is sorting out all our dysynchrony or asynchrony problem. So Better Care is a software algorithm that is incorporated in certain ventilators where your dysynchrony is taken care of by the ventilator itself. So as we understand, increase in the pressure assist or volume assist leads to increase in the tidal volume, and increase in tidal volume has shown to reduce the inspiratory effort. If your tidal volume delivery is higher than the patient demand, that will abolish your inspiratory effort. So you are giving more tidal volume than what he needs. That will take away patient's inspiratory effort, and that is shown to cause your diaphragmatic atrophy. And NAVA, neurally assisted ventilatory assist, neurologically NAVA ventilation, I'm sure many of you would have heard. Here, this is the ventilator sort of a situation where you have inspiratory assist, which is directly proportional to the electrical activity of diaphragm. If inspiratory assist is increases, then your electrical activity of diaphragm is decreased by neurologically assisted ventilation. So, and tidal volume remains constant in NAVA. So is there any sort of a clinical evidence to suggest NAVA is superior? So these are the trials that has come from Spain and Netherlands. So where they've compared NAVA versus pressure support, and some studies have shown that NAVA is shown to reduce the duration of mechanical ventilation. So here basically it is modulating between your inspiratory assist and the electrical activity of diaphragm. So if your inspiratory assist is more, it reduces your electrical activity of diaphragm. So the tidal volume remains constant. That is the principle. So we'll not dwell into the details. So this is some figure I just want to explain as to why all these pressures are important. So this is extremely important for all the trainees. So this is the typical sort of a situation we see in ICU where certain alveoli is collapsed. And I want the listeners to appreciate what happens during expiration and inspiration. During expiration, you provide only PEEP, right? So then what is transpulmonary pressure? Transpulmonary pressure is the difference between airway pressure and pleural pressure. So here transpulmonary pressure in the recruited alveoli is 6. In the unrecruited alveoli, it is 7. And this is not good enough to open this alveoli. During inspiration, along with PEEP, you have put pressure support. So in non-dependent lung, non-dependent means this is a recruited lung, transpulmonary pressure becomes 15 and transpulmonary pressure on dependent is 18. And this here there is over distension of alveoli because this was already recruited. Here you are providing transpulmonary pressure of 15, which is not needed. That leads to volume trauma. And this is not a good situation for us. So then we look into a situation where both are recruited during inspiration. So here there is no problem. But here you see there is a recruitment with possible over distension that is not needed. But in inspiration, here you look at this situation, you have provided a PEEP of 14, but you have reduced the pressure support by 3. And what happens? Your transpulmonary pressure is 19. On the right is 22. That is compatible. So the only difference what we are seeing here is by modulating pressure support, you are trying to achieve a state which is compatible with lung protection. So there is a separate video on this. Please watch this. This is extremely important as to what happens to collapsed alveoli during inspiration. And the most deleterious effects happens during inspiration because pressure support is added, more tidal volume is delivered, transpulmonary pressure goes up, that leads to the problem. So your whole concept is when tidal volumes are increasing, you have to bring down the pressure support because that is compatible because PEEP is not shown to be harmful. It is the pressure support and its concomitant increase in the tidal volume, which is shown to cause more harm to the lung. So titrating PEEP, we won't go into the details. There are various ways of titrating PEEP, but what has shown is high PEEP will shorten your whole diaphragm muscles, which leads to longitudinal atrophy. And when this PEEP is rapidly reduced, there is sudden stretching of this diaphragm and it goes into atrophy. And as we spoke about patient ventilator synchrony, and our whole effort should be to resolve. NAVA is one way. There is something called proportional assist ventilation, which reduces asynchrony. Over assistance is prevented. And as I said, artificial intelligence is being incorporated into ventilator algorithms so that ventilator assesses the breath and provides the breath in synchrony to the patient, and dysynchrony is avoided. So there are some studies. This is one study from China where they have assessed 5,899 breaths in a ventilated patients, and they found 58% of the breaths delivered by the ventilator were dysynchronous or was ineffective, and AI was able to rectify this with sensitivity and specificity of 98%. This was another study by France where they showed there was a lot of divergence between the flow time and the flow volume loops. There was a deviation of more than 42%, which means there was a dysynchrony prevailing. In 16 breaths, they assessed, and the sensitivity specificity was very good. And better care is the AI software that is incorporated into certain ventilators, which sorts out all this dysynchrony and asynchrony problem. And this is where we are heading. And this was another study where they looked at ratio between exhaled tidal volume and inhaled tidal volume as a marker of dysynchrony, and that also sensitivity. So basically, these two slides are about artificial intelligence making inroads to sort out the dysynchrony. So we don't need to break our heads to identify this dysynchrony, because dysynchrony and asynchrony happens from breath to breath, and it's very hard humanly to fix this on a in a very exact way or in a very definitive way. And sedation strategies is very important. As I already mentioned, over sedation is bad, under sedation is bad. So the light sedation, depth of sedation is important, because the lighter sedation has shown to reduce mechanical ventilation, reduce ICU length of stay, grade 1B, and monitoring depth of sedation has to be done with RAS score, and daily sedation interruption with lightning has to happen. In all this, I won't dwell into detail. I'm sure most of you know. And analgesia first sedation, and early mobilization is something is being emphasized. It is shown to reduce the delirium and duration of delirium and improve the weaning process. And one has to take effort in protecting the sleep cycle, which also grades grade 1C recommendation. So the last slide, the summary, I may have exceeded the time. So the lung and diaphragm protective ventilation, the first aspect of it is to attain respiratory homeostasis. For that, we need to avoid unnecessary or significant respiratory acidosis, and our whole goal should be to maintain normal oxygen or acceptable oxygen. The lung protective strategy, the whole effort is to reduce the lung stress and reduce the respiratory muscle effort, and to reduce asynchrony. These are the three key pillars of protecting the lung and the diaphragm. So the stress on the lung should be less, stress on the diaphragm and the respiratory muscle should be less, and there should be reduction in the dysynchrony and asynchrony. And that's where AI comes to our help. And your diaphragmatic protection happens by creating respiratory dive, which is optimal. Right now, we have a practical tools where we looked in the change in the pressure with inspiratory effort against an occluded airway for 0.1 second, which is readily available on ventilators. And sedation should not be oversedated or undersedated. PEEP should be optimal. Too much PEEP is bad for diaphragm, less PEEP is bad. And we discussed about this pressure, which is 1 to 4, and improving the patient outcome with an intent to reduce mortality. And weaning should be hastened with optimizing diaphragmatic function, because you wean them faster, reduces the risk of nosocomial infection and reduces the risk of neuromuscular weakness, improve the functional outcome and quality of life. So thank you one and all. So I would end with this beautiful quote. So again, my sincere apologies for not being in person. So possibly maybe I'll take sabbatical for 2-3 months. So I wouldn't wish to be traveling because of whatever reason I said. So you can listen to this. This may be an overwhelming topic. So you can visit my website to rehear to this lecture. And along with this, please watch the video on diaphragmatic assessment, because that's a sonological assessment, which is the more practical way of assessing your diaphragm optimization. So thank you one and all.